Hello and welcome to this VJHemOnc podcast. This podcast is part of the acute myeloid leukemia channel on VJHemOnc, which is supported by funding from VMS and through an educational grant from Jazz Pharmaceuticals. These supporters have no influence over the production of the content. This podcast is intended for healthcare professionals only. In this episode, we explore the evolving role of measurable residual disease, or MRD, in acute lymphoblastic leukemia and acute myeloid leukemia. MRD is increasingly recognised as one of the most powerful prognostic tools in hematologic malignancies, but its role is still being defined, particularly in AML. We will hear from leading experts on how MRD is shaping clinical decision-making, the challenges of standardisation, and its potential as a surrogate endpoint in clinical trials. So, let's begin. One of the key debates in AML is whether MRD can be used as a surrogate endpoint for survival in clinical trials. Erba discusses both the promise and the complexity of this approach.
So the debate is on measurable residual disease as a proper surrogate endpoint in AML. And I've been assigned the affirmative end of the argument. It's clearly a very important position to be able to take, but also to prove that MRD is a proper surrogate endpoint. And the reason for that is currently our approvals of new drugs are depending on showing an overall survival benefit in people with acute myeloid leukemia. And those phase 3 trials take years to complete, to design and complete. And by the time they're completed, new questions have come up. And so we need to move quicker, especially in the era where we have novel therapies being developed and being brought into frontline therapy for patients with acute myeloid leukemia in order to try to improve the survival. So we need a powerful surrogate that correlates with overall survival. Now, the challenge in doing this is what MRD assay are we going to use? Flow cytometry, PCR, RT-PCR, FISH, there are a variety of them. What tissue, peripheral blood or bone marrow, at what time point immediately after induction? Is that 1 or 2 cycles of induction after consolidation? And so there are a number of questions that we don't have answered yet. And of course, these assays have not been validated and standardized internationally, including what is the most appropriate cutoff that is informative at predicting the surrogate endpoint, in this case, overall survival. What complicates the matter in large phase 3 studies is that patients are able to undergo allogeneic stem cell transplantation after they've achieved remission. And allotransplant, through the graft versus leukemia effect, has the greatest impact on measurable residual disease. And so it can end up negating any benefit that may have been seen by the intervention to induce an MRD negative remission, complicating the interpretation of clinical trials. Nonetheless, I think there are situations where we can consider MRD a proper surrogate. One endpoint for my patients with acute myeloid leukemia is avoiding the toxicities, the morbidity, the mortality associated with allogeneic stem cell transplantation and first remission. And I do think we now have enough data using an MRD assay, the RT quantitative PCR assay for the NPM1 mutation, that help us decide which patients may benefit from an allotransplant in first remission and those who may not need an allotransplant in first remission. Now, of course, no assay is perfect, and patients who are MRD negative by that assay and don't undergo a transplant may end up relapsing. However, in NPM1 mutated disease, we have a number of options. If the patient just received chemotherapy, they could receive gemtuzumab ozogamicin plus chemotherapy. They can receive venetoclax-based regimens, either with intensive or non-intensive chemotherapy. And then, of course, we have the menin inhibitors, and all of these are going to be combined in different combinations for patients with relapsed disease. So I think we'd be able to salvage those patients and then direct them to allotransplant. There's another place where the reverse transcriptase quantitative PCR assay for NPM1 can be actually quite helpful and informative for patients. In those patients receiving less intensive therapy with a hypomethylating agent of venetoclax who have NPM1 mutated disease, we know that some of these patients may very quickly, within a year of treatment with a Ven-HMA combination, achieve a very deep remission that's MRD negative by this assay. Some of those patients may actually be able to go on to treatment discontinuation and remain in a treatment-free remission. I have such patients in my own clinic who've been out 3 years from therapy, having achieved an MRD negative remission after just venetoclax and azacitidine. And these have been reported in case series. However, as a proper surrogate endpoint for regulatory approval, I know of only one study that has prospectively evaluated a specific MRD assay at specific times along the course of the treatment protocol, and that's the Quantum First study. In that study, patients who were up to and including the age of 75 with a FLT3 ITD mutation received initial therapy with standard 7 and 3, followed by high-dose cytarabine, in combination with either quizartinib or placebo during the induction consolidation, and then as a maintenance for up to 144 weeks. We know that quizartinib was associated with a survival benefit. But what we learned from that study, where we prospectively captured these samples from bone marrow specimens, is that patients who received quizartinib were more likely to become MRD negative by a very sensitive next-gen sequencing FLT3 ITD specific assay compared to those who got placebo. And the median variant allelic frequency was also lower following induction and consolidation and prior to maintenance in patients receiving quizartinib. To me, what's remarkable is in patients who became completely MRD negative, not only were there more of those patients in the quizartinib arm, however, in patients who were MRD negative who did not undergo an allogeneic stem cell transplant in first remission, there was a survival benefit with quizartinib compared to placebo. Now, this is very important to me because although many of my patients should be considered for allogeneic transplant at first remission, we know that it's only the minority in the phase 3 Quantum First trial and in clinical practice who are actually able to undergo allogeneic transplant. You may not know this on the first day that you're meeting the patient. And so in my opinion, this supports the use of quizartinib in the FLT3 ITD mutated patients, and the MRD data supports that the general benefit of quizartinib in that patient population. So I think going forward, we need to be mindful of the need to actually develop, to validate, and to standardize these assays, which may be different across different subsets of patients with acute myeloid leukemia, and incorporate those assays into well-designed clinical trials in order to try to prove that MRD is a proper surrogate endpoint, not only in FLT3 ITD mutated AML, but in other subpopulations of people with acute myeloid leukemia. So we're not waiting another 10 years for the next phase 3 survival study to read out.
As highlighted, MRD has the potential to accelerate drug development, but significant challenges remain, particularly around assay selection, timing, and standardization. Despite these challenges, emerging data suggest MRD may serve as a meaningful early indicator of treatment efficacy. Bruno Paiva shares insights from a large registry analysis exploring MRD as an early endpoint in AML.
The outcomes that were achieved, for example, in myeloma, regarding the use of MRD as an early endpoint of treatment efficacy in clinical trials, as this was endorsed by the FDA in 2024 and by EMA in 2025. So what if not only in myeloma and CLL, but also in AML, MRD could be used as an early endpoint of treatment efficacy? Now, learning from the myeloma lessons, if we want to use it in AML, we need to clearly show that it is of higher sensitivity, superior to conventional complete response, that it has independent prognostic value, that it is applicable to patients regardless of cytogenetic risk, and that MRD negative rates are to some extent associated with the impact that different treatments have on patient survival. So in this very large study that leveraged on the huge data set collected by the PETIMA group in Spain, we show that MRD is indeed more sensitive than CR. Almost 70% of patients in CR have detectable MRD above the 0.01% threshold, and this is associated with inferior survival. We also show that it is of independent prognostic value regardless of induction as well as genetic risk. And we show that there is an association between different MRD negative rates with induction and the survival outcomes that patients had with those different induction regimens. This is not definitive data, but I think this is promising data suggesting that indeed MRD may have a role as an early endpoint of treatment efficacy for AML clinical trials.
Together, these findings reinforce the growing role of MRD, not only as a prognostic tool, but potentially as a more sensitive measure than conventional response criteria. Beyond clinical trials, MRD is also playing an increasing role in refining risk and guiding treatment decisions in AML. Amin Turki discusses how MRD is being integrated into large-scale research efforts to better predict outcomes and enable earlier intervention.
This is another activity of us at the Harmony Alliance Foundation. We are following also the other risk factors that are relevant to AML, because although genetics at initial diagnosis, what we have been focusing on in my abstract, is a hallmark attributing to about 63% of the factors that are relevant for prognosis, it's modified with other factors, including age and also other factors such as treatments. But the MRD, so the minimal residual and measurable residual disease, are adding value, and they are refining risk for those patients after the treatments, because the persistence of MRD is a risk factor, an independent risk factor. More importantly, and this is what my colleague has been focusing on, is a factor that really can be utilized as a surrogate parameter, because it becomes positive earlier. And this has impacts, of course, to clinical trials, because clinical trials usually wait for the signals which are mortality or relapse signals. But if you can detect them, anticipate them, you can accelerate the treatment and you can intervene earlier when it's better to cure patients, for example, with an allogeneic transplantation. And the surrogacy of the MRD has been investigated previously, but not on that scale. And he was able to merge data for 1,800 patients to really investigate this diverse impact of the MRD. So good updates, hopefully also for the patients.
While MRD is still being validated in AML, in ALL, it is already well established as a key predictor of patient outcomes and a guide for therapy. Wendy Stock explains the current landscape of MRD detection in ALL, including the strengths and limitations of available technologies.
I think the controversies are that it's an outstanding biomarker if it's able to be monitored. There are some patients who, for example, don't have a detectable clone if we're using NGS-based MRD methods. And so that's a limitation. Flow-based MRD is usually informative in almost all patients, but it's not as sensitive as the next generation sequencing techniques. In addition, the NGS techniques have not yet been validated or completely approved for T-ALL. So in that setting, you still, the standard of care, I think, is flow-based MRD for T-ALL. I think in North America, probably in Europe as well, the standard for B-ALL in general is NGS-based MRD detection, but that's not always informative. It's informative in the vast majority of cases, but you can't always detect a clone. It's also expensive and not universally available. And I think in the early studies, there were some studies from the MD Anderson which suggested that patients with PH-like ALL who are MRD negative still had poor outcomes. I think with an NGS techniques now, if patients are truly MRD negative, we're seeing that it's probably quite if it's a robust marker for a particular patient, it's highly predictive of outcome, I think, for almost any subset of ALL. And I don't know of one where it would not necessarily be predictive of outcome.
These differences between MRD detection methods are not just technical. They can directly influence how response is interpreted and how treatment decisions are made. Nicholas Short discusses how next-generation sequencing is reshaping MRD assessment in Philadelphia chromosome-positive ALL, and how this compares with traditional PCR-based approaches.
So in Philadelphia chromosome-positive ALL, historically we've used PCR for BCR-ABL as our MRD marker. There's multiple studies that have shown that this is an important prognostic tool, and that patients who have clearance by PCR for BCR-ABL do better than those who do not. But now that we have, NGS MRD, specifically the clonoSEQ assay, which we use in the US, I think that there's been a lot of data challenging that PCR for BCR-ABL is really the optimal tool. For example, NGS-based MRD is more sensitive and likely also more specific for the actual lymphoblast clone. So we previously published that, about a quarter of patients who are clonoSEQ negative might still have persistent PCR positivity. And this is something that we wanted to look at more in this abstract. So we identified, again, about 25% of patients who will achieve clonoSEQ negativity, but still have persistent PCR for BCR-ABL. We looked into those patients. We found no difference in long-term outcomes between those patients who were PCR positive versus PCR negative, as long as they were clonoSEQ negative. And it also didn't matter the quantification of the PCR. So even if they had a PCR of 0.1% or even 1% or higher, they still had excellent outcomes that were no different than those patients who were PCR negative. So I think we're really moving in the field to think about NGS-based MRD rather than PCR for BCR-ABL to do our risk stratification for these patients. In this abstract, we also describe a couple patients who had this PCR positivity but were clonoSEQ negative, and we discontinued the TKI. Well, actually, the patient self-discontinued the TKI, and we found that the PCR rapidly rose, suggesting that we should probably continue the TKI for these patients with persistent PCR positivity. So in my own practice now, we really rely on the clonoSEQ or NGS MRD assay for all of our risk stratification decisions. But the PCR is helpful because we do not consider stopping the TKI for patients who are PCR positive, versus after patients have been, PCR and clonoSEQ negative for at least 5 years, we often consider stopping the TKI for those patients since they are likely cured from their leukemia.
As technologies evolve, improving sensitivity and applicability across patient subtypes remains a key focus. Wendy Stock also highlights emerging approaches, including next-generation sequencing and digital PCR, which may further enhance MRD detection in ALL.
And I think the NGS technique is highly sensitive. And so if we can expand that and validate it in TALL, that would be highly useful, because that makes up in the young adult population up to 30% of our patients. And so I think that will be important. I don't know of additional new techniques. There are these digital droplet PCR assays that can be implemented potentially for very high-risk subsets like the KMT2A rearranged ALL. I know there are a number of groups working on that sort of approach that have not yet been completely validated, although validation studies are ongoing for that. So I think some of the digital droplet PCR for specific fusions will be useful. And then NGS as a broad stroke for most patients with BALL. At this moment, high sensitivity flow cytometry for TALL, I would say, is still the standard of care, although many patients with TALL probably have robust markers that can be tracked, but it's just not it's not 100% validated yet, and it's not yet FDA approved in the United States for monitoring TALL.
Despite these advances, access to MRD testing remains a challenge in some settings, making practical implementation an important consideration. Professor Stock offers practical advice on how clinicians can incorporate MRD testing into routine care, even when resources are limited.
I think it's really important to try to get some form of MRD testing done because it's so prognostically relevant and it helps us dictate the post-remission therapy. So I think in most places, even if your center doesn't have the opportunity to do these techniques, you can contract for both flow and for these NGS techniques to send out the sample. And for the NGS techniques, we, for example, send out our sample. We have within our lab at our university hospital, we have outstanding flow, but if you don't have that, there are companies where you can send the specimen and quickly get turnaround. So I would say that in terms of, at least in the United States, where access to these tests is not an issue, you can contract with these outside organizations, pharmaceutical, biotech companies, to do these kind of assays. I think in under-resourced parts of the world, that's a totally different question. And then you have to go based on the clinical outcomes. And all you can do with that is give your best approach in terms of sequential therapy for ALL. And I think you can see if patients are not having a rapid clinical response, then you have to worry and potentially change treatment and move towards an allotransplant. Of course, in under-resourced areas of the world, that's also not always an option.
Overall, MRD is transforming the way we assess response and guide treatment in both ALL and AML. While its role as a surrogate endpoint in AML is still being defined, growing evidence supports its potential to accelerate clinical trials and enable more personalised treatment strategies. At the same time, advances in detection technologies are continuing to improve the precision and utility of MRD assessment, particularly in ALL, where it is already central to clinical decision-making. Thank you for listening. To explore more expert insights and interviews, head over to VJHemOnc.com. Be sure to follow us on X at VJHemOnc and subscribe to our podcast on Spotify, Apple, or Podbean. Until next time.